here, so pleased to have her. Hi there, thanks for having me. I'm going to talk a little bit about overdose education and naloxone distribution. I, of course, turned it into an acronym, OEND, part of the field, acronyms. But I want to put this into context a little bit before we jump into that. So these are just a few selected strategies to address overdose and in the U.S. And we, it's worth pointing out if we're, we talk about definitions. The technical definition that the epidemiologists use for opiate overdose is a poisoning. So there's talk about removing overdose and talking about poisoning so that we're not unintentionally focusing on the folks who we normally think overdose and expanding the risk of opioid poisonings to people who are engaged in taking opiates for chronic pain. So anyway, so there's several strategies to address overdose, but there's many. I just wanted to pick out a few to contextualize over OEND. So one is prescription monitoring programs, and these vary from state to state. There's some research out there that shows that they're effective in reducing fatal overdoses. There's some research that shows that they're not really effective in reducing fatal overdoses. The jury's still out on exactly what is the best model of a prescription drug monitoring program to achieve the best results. This is pretty new research, and there's a lot of debate about how to implement in the best way to reduce fatalities. There's prescription drug take-back events. I think one's coming up at the end of April, maybe the 27th. Does anybody know that? DEA take-back days. So the idea behind these events is that because certain prescriptions are scheduled drugs, there's only certain people who are allowed to be in custody of them if it's not the person for whose prescription it is. And so the DEA or the police have to be around to attain custody of these scheduled pharmaceuticals. And so every so often the DEA will get together and throw around posters and say, okay, this is the day, come in community, clean out your medicine cabinet, drop off your prescription drugs, don't flush them down the toilet, etc. The idea behind this is to get ambient pharmaceuticals that might contribute to overdose out of the community. There's no research on this. Nobody's even trying to figure out if this is an actual, well, that's not true. There's currently no research on whether or not prescription drug take-back events reduce overdoses. There's abuse deterrent formulations, and specifically I'm talking about like the transition of OxyContin OCs to OPs. So they're gummy and they're hard to crush up and inject, and this was pitched as a way to reduce illicit use of OxyContins. Interestingly, there's this article that came out in the New England Journal last year shows that indeed these abuse deterrent formulations have reduced the number of people using and overdosing on OxyContin. However, that gap that was made by those folks was filled in by those people transitioning to using and overdosing on heroin. In fact, you can actually see the graph goes down for OxyContin and up for heroin at the moment when this change happened in 2010. So this is an interesting one, and it's pitched. I mean, the pharmaceutical company is pitching this as this is a safety strategy that we're undertaking. There's safe opioid prescribing education, and this varies pretty seriously as well in terms of how it's implemented or different ways to get educated and safe, a prescriber to be educated in safe opioid prescribing. This particular study was out of North Carolina, where they have a really, really robust prevention program that is implemented in rural North Carolina. This particular study showed that in the year before implementing this, 82% of the people in that county who overdosed on prescriptions that were prescribed to them by prescribers in that county. The year after implementing, only 10% of the overdoses were on prescriptions that were prescribed by prescribers in that county. Expansion of opioid agonist treatment, specifically I mean buprenorphine or methadone, is a very well-researched and established way to reduce heroin-related deaths amongst people who are heroin dependent. In fact, I think it's 75% reduction in fatality is extremely effective. Supervised injection facilities were mentioned earlier, and there are no supervised injection facilities in the US. This particular study was out of the supervised injection facility in Vancouver, Canada. They showed a 35% reduction in fatal overdoses in the area right around where the facility was. And then finally, there's take-home naloxone, or OEND, overdose education and naloxone distribution, because it's not just about the naloxone, it's not just about the take-home naloxone, there's some education. And this study shows, I'm actually going to talk a little bit more about this study, but it shows that that it is also a really effective way to reduce fatal overdoses. I'm going to talk about this. It's what I know the most about, and I also wanted to point out that in Illinois, the first OEND in the country was established. The Chicago Recovery Alliance, I think Dan's around here somewhere, but he's an incredible resource, helped me get working on one in Massachusetts. So that's cool in Illinois. To further contextualize where these interventions to stop overdose fit in, I just wanted to show this little slide, and I've heard that can anybody see that? Probably not. We'll start on the left side. So what we have is, in the very beginning, we have prescription opioid misuse that maybe leads to heroin use, or maybe leads directly to a non-fatal overdose. One does not necessarily mean the other, but it can. And so you have misuse of prescription opioids and heroin use, and you have a non-fatal overdose that can turn into a fatal overdose, right? So that seems pretty simple, but I just want to point that out, that the risk factors for these different stages in an overdose are, at the very beginning, we have prescription drug diversion. And then over at the far end, the non-fatal, possibly progressing to a fatal, the risk factors that we know are polydrug use, abstinence, meaning having figured out, got together a period of time of not using drugs and then using again. The most common causes of this are incarceration and drug-free drug treatment. Using alone doesn't actually increase your risk of overdose, but it increases the risk of dying from an overdose since there's nobody there to intervene. And an unknown source of drugs. So we see that the opioid addiction prevention and agonist treatment addresses overdose at the far early side, and that overdose prevention and education addresses the risk of overdosing in the first place, and then overdose management and giving people naloxone is where the fatal overdoses get attacked. And so the supervised injection facilities also address the using alone issue and the availability of naloxone. And these other interventions, like prescription monitoring programs, prescriber education, drug take-back days, and abuse deterrent formulations, they work at the beginning of this process. So the point is that we probably don't have a single intervention that is, regardless of the science, we don't really have a single intervention that is going to be the answer to overdose and opioid poisonings. So we probably need a mix to address all of these stages. So the rationale for bystander overdose education and naloxone distribution is pretty solid. Many opioid users do not use alone. Let me back up. Along the bottom here, you'll see several different photographs of naloxone. On the far left is a nasal formulation that has a post-market adapter put on that you can spray up somebody's nose. The next one over is a kit put together by, I believe, some folks in San Francisco. And there's a 1 milliliter vial of intramuscular intravenous injectable naloxone. There's a larger vial there, and then this kit put together, I think out of New York, is over on the right. So that's naloxone. So many opioid users don't use alone, and the ones who, even if I use alone at the moment of consuming the drugs, I'm often around people for the duration or at some point during being high and possibly overdosing. So that's one rationale. We know there are some risk factors that we don't know, but there are definitely some risk factors that we do know. So we can address some of these risk factors with education and providing tools. there's a big opportunity window. So overdoses are rarely instantaneous. It's certainly possible, but it doesn't happen often. Usually an overdose takes minutes to hours after having ingested an opiate, and it's reversible with naloxone. Bystanders are trainable to recognize overdose. We've definitely established that. This doesn't have to be really sophisticated medicine or incredible amounts of training or licensure. People who are just lay folks like you and I can be trained pretty quickly to recognize overdose. And then there's a fear of police, and that really affects people's willingness and ability to access existing safety mechanisms like calling 911. So to be clear, to make this whole thing work, an equipped bystander is the key, and these are the elements that must happen, right? So bystander has to recognize an OD. You know that that's possible. Bystander has to be equipped either with naloxone around them or knowing how to do rescue breathing. So opiate overdoses are all about oxygen. When somebody overdoses, it's a slow progression of slowing down breathing and then finally stopping breathing. And so if somebody can be provided the oxygen that they are not getting themselves because they're not breathing, then people will often survive overdoses too. So naloxone it's not the only answer to addressing opiate overdoses. And then the bystander must be willing, and this is something that is, I think, really interesting. Bystander has to be willing, and so these are categories of folks who are likely willing to respond to an overdose: a loved one, neighbors, public safety, social service providers, and very specifically drug-using peers. That is the bulk of the folks who are recognizing and responding to overdoses. But I think this is really interesting because a lot of the studies that are out there on training lay people for CPR or, I guess CPR is what we're talking about, is that those studies are done on folks who sort of drop down on a sidewalk, and what does what do bystanders do when somebody sort of collapses? And it's really interesting that they find that people really are not often willing to do something. They don't want to give mouth to mouth. It's a stranger. And so this is kind of a different situation because often there are willing bystanders and people care about these folks, and it's not a stranger who drops down of a heart attack on the sidewalk. But I really wanted to highlight this drug-using peer thing because this is where this intervention was conceived of. This is where it was implemented in for the first time at the program that Dan Big runs, is with people who use drugs with other people who use drugs, right? So on the ground, this is actually data from the Massachusetts project that I was a part of, and we have a really, really thick, huge, robust data set on all of the people that have been enrolled since 2006. So I wanted to point out on the left side, we have enrollments, right? So 70% or so, the blue, are people who are drug users, who self-identify as being a drug user. And the red are non-drug users. And so these are people who are friends, family, loved ones, parents, social service providers, neighbors, concerned citizens, but people who are not identifying as drug users. So that's enrolled. And then if you look over on the right side, we have the rescues. And so almost 90% of the people who have rescued, who've come back to the program and said, look, I was in the presence of an overdose, I had my naloxone, I used it, did something, I need another Narcan kit. Almost 9% of them were drug users. And so I think it's just really important for us to remember that there may be lots of stereotypes around drug users that we have, but it's an incomplete stereotype if we're thinking that people who are drug users don't quite care enough, are only going to dump bodies, only care about somebody overdosing because they're going to steal drugs or money from the person who overdoses. It's really, it's a stereotype, and it's an incomplete story, and this is a story of drug users who really act and save people's lives. So, what's the reach of these programs? How many are there? So in 2009, there were 48 programs, and in that year, this is in the country, right? And in that year, those 48 programs distributed 38,000 doses of naloxone. In 2012, this survey was redone, and if there's any media here, please don't disseminate this. The person who did the survey told me that if she finds that these data get out from telling me that she's going to yell at me. But so in 2012, there were 60 programs, so there's 12 more programs than in 2009, that distributed 52,000 doses of naloxone. So is that big? Is that not big? Who knows, right? There's 60 programs in the entire country. 52,000 seems like a big number to me, but I think that it could handle to be bigger. So does it work? This is some research that just recently came out about the effectiveness of naloxone. So on the left-hand side, we have naloxone coverage per 100,000. So when we did this research, we split up communities and figured out how many people had naloxone in those communities for every 100,000 population. So what we found is that when there's zero implementation, there's no effect on fatal overdose, right? If you enroll between 1 and 100 people in those communities, come on, animation. There we go. Isn't that impressive? I was very impressed with myself. I kind of want to do it again. So if you enroll between 1 and 100 people in a community, you will see a 27% reduction in fatal overdose rates. If you enroll beyond 100, and it ends at 250, I'm not quite the cleverest animator, I was impressed with that, but it's anywhere above 100, and then the 250 is not the top mark. But if you enroll more than 100 people per 100,000, what you see is a 46% reduction in fatal overdoses. That's nearly a 50% drop in fatal overdoses by giving people in the community naloxone. So does it work? The answer, to me, that's definitely yes. Is it expensive? This is another question that people often have, and you're like, well, if you have such an effective intervention, it must be really expensive. So Philip Coffin just published this simulation model, because it's really kind of hard to figure out cost effectiveness when you have splotchy implementation. So he did a super fancy computer simulation model that I don't totally understand all the details of, but I know how to read the results. So the cost is approximately is $400 for every quality adjusted life year. So that's about $1.10 per day per life continued. So in that sense, I don't think that that's expensive. And I know that insurance companies, there's a threshold that says at which point something becomes cost effective or not cost effective. And I think currently in the US that is $50,000. So according to those rules, this is also cost effective. So is it legal? So in the US, in general, a physician who has prescribing authority can prescribe naloxone, which is a prescription medication, to any of their patients who's at risk for an overdose. That is just sort of normal medical practice. In Illinois, there's further protections because it's kind of a unique situation, right? I get naloxone that I might use on another person. This is a prescription medication. It's kind of a unique situation. So in Illinois, as Kathy and other people in the room really advocated for this legislation that passed that allows for what's called third-party prescribing. So that is, I'm the doctor, you're my patient, I write you a prescription knowing that you're going to use it on that person. So that's sort of third-party prescribing. And the other models that we have for that in the US are things like expedited partner therapy for STDs. So if I go to my doctor and I have gonorrhea, my doctor can prescribe myself and my sexual partner treatment for that. So that's another similar model around third-party prescribing. Distribution by non-medical personnel is also authorized, which is really, really key because it keeps this cheap. Doctors are expensive, so there's a little bit of medical oversight, but it means that a layperson with the approval of a medical provider can actually give out this medicine. And there's also overdose rescuer liability protection, and this is also important because that situation where she has a prescription and then uses it on that person, there's the possibility that that could be interpreted as something like practicing medicine without a license. And given that this intervention has been operationalized with people who are often involved in illegal activities or illegal activities if we're talking about heroin, that's helpful because they're already really vulnerable to law enforcement. So, specifics. Just to be clear about a couple of things. Narcan is the brand name of naloxone hydrochloride. In different places, you'll hear Narcan used more often, and in some places it's naloxone. It's all the same. Narcan is the brand name, but it actually isn't, like naloxone went off patent, so it's not even out there as, like, you can't find a box that says Narcan on it that's sold these days, but it's still a word that's been around and part of the lexicon. So Suboxone is buprenorphine plus naloxone. The naloxone is added to keep people from injecting the Suboxone. That's not hugely effective, but that was the point. Subutex is just buprenorphine, so that's a little bit different than Suboxone. And naloxone is not naltrexone. So naltrexone is a long-acting opioid antagonist. It goes by brand names Vivitrol and Revia. Those are not the same. They're both opioid antagonists, but short-acting and long-acting, so that's that. So specifically, mixing drugs puts people at risk for overdose. We talked about knowing what the risk factors are. And there's a lot of reasons why people mix drugs. Often it's intentional and it's thought out, and there are ways that people can mix drugs in a way that is going to put them at less risk, or mix drugs in a way that's going to put them at more risk. So having a really in-depth dialogue with folks about how they use and what order they use, and rationales for mixing is good prevention. So when folks use drugs that are illegal, their purity is simply unknown, so that's a risk. Tolerance changes coming out of jail and treatment. And it doesn't have to be a really long time. I think seems like it's pretty common knowledge that people who, have stacked up 8 or 10 or 12 months of time being abstinent from opiates are at risk, but it doesn't have to be a really long time. We can talk about like a 3-day detox even would drop somebody's tolerance, or even something like a hospital stay. If I got sick and was hospitalized for a couple days, that is something that those short events also can affect tolerance. We talked about using alone. It's not that in and of itself doesn't put people at risk for fatal for overdosing, but it's that nobody's there to help. Physical health. This is one of the areas that is really still being studied and researched, because it's not hugely clear how these mechanisms affect overdose, but definitely liver function, weight loss, and smoking affect people's overdose risk. And smoking is interesting because, people overdose because they slowly stop breathing, and if you have a lot of smoking that you've been doing, your lung function is a little bit diminished, and I think there's a lot of smoking there. So I think that folks sometimes forget about that. People who, not all drug users have transient living situation, but for those who do, those systems of new dealers and new products are really, it makes people vulnerable because you just don't know exactly what we're getting. Thinking you know everything. This is something that I think affects younger, I think I know everything, right? But I think that this is something that it uniquely shows up in younger drug users. So there was a time when a lot of people who got to heroin use sort of were mentored to heroin use by people who knew how to use heroin. And there's a wider way there's a wider range of ways that people use, and sometimes people start, if we're talking about that prescription to heroin transition, if people are transitioning to a drug that is not really in their social network without the support of known people who have some experience under their belt, I think that's where this really shows up in younger drug users. And so switching routes of administration, switching from swallowing or snorting to injecting. So these are prevention messages that really are really, they're more for like interpersonal, like people who actually have relationships with somebody who's using. So it's okay to say to somebody, I want to remind you that your tolerance is low and you're at high risk for overdose. It's just putting that out there on the table and having a conversation with somebody about, I know that you're at overdose risk, you know you're right, so your tolerance is low. Saying it, just putting the words out in the room is powerful. Asking if people have an overdose plan. Do you and your friends know about Narcan? Where is it? What, is it with your injecting equipment? Is it in your glove compartment? Do we actually know how to get at the stuff if we need it? I care about you, even though I don't like what you do. I don't want anything to happen to you. That's a really, really powerful statement. It sort of hijacks the intensity, especially in families and close friends, when somebody is having chaotic drug use happen in their life, and they know the tension is there, and the desire to get that person abstinent and pull things together is there all the time. And so hijacking that consistent pressure just for a second to say, just so we're clear, I care about you, I love you, that's really, it's powerful. And it really changes the way that people can have conversations about drug use. And this one's kind of hard because if I am in a relationship with somebody who has stacked up some time abstinent and is going to relapse, that person knows that they're going to be disappointing me. And so they're going to be wanting to, they're not around me, right? So this is an intense concept to say, if you relapse, please don't do it alone. And notice that that just means just don't be alone. It's not like you have to say, guess what, Maya, I'm doing it and I'm gonna go in the bathroom right now. It could be somebody who doesn't have quite such a strong relationship with people being abstinent, but that's also a part. So, how do opioids affect breathing? So these little gray guys are opioid receptors, and so opioid receptors in the brain, and opiates get introduced into the body, and they sit on those receptors. So the more of them that get filled up slowly depresses breathing, and sometimes, there we go. I did that. That's awesome. So when too many opiate receptors in the brain get connected with opiates, they slow down the breathing. So pretty simple. Opioids, there's not only opiate receptors in the brain, there's also some like in the intestinal tract, along the spinal column. That's part of the reason why people who use opioids get, constipated. So, there we go. Oh, I had another animation. So that's an overdose when there's too many opioid receptors that are occupied by opioids. So differentiating between really high and an overdose is sometimes kind of hard because there are some similar symptoms. So if you're really high, you probably have pinned pupils. If there's an overdose, pupils pinned. This is key, right? So if you're really high, you can be nodding but not arousable. If I yell at you or do a sternal rub, somebody I know calls it a chest noogie, which I actually really like. So responding to stimulation or even just yelling at somebody who's really, really like bent over and nodded, people will be arousable if they're just really high. If people are not arousable, like there's no response to a sternal rub, it means that they could be having an overdose, right? Speech being really being slurred is something that can happen when people are really high. And this is the key thing, right? This is like the sort of definer about overdose versus really high is breathing. So breathing 8 or more times per minute 8 times per minute is kind of slow in the range of normal, but anything less than 8 times a minute is problematic. You may hear a sort of a choking or a gurgling noise, and this is one thing that I try to, when I talk with people who are not drug users, to really pay attention to that sleeping gurgling noise, because it's really, really tragic when you talk to somebody who said, I actually heard that, and I thought my kid was sleeping. But it's not exactly snort. It's sort of like a, so it's slightly different than a normal snort. Blue lips and fingertips, this is the result of not breathing enough, right? So lips and fingertips are the first ones to get blue, but sometimes people's whole bodies are blue. So if somebody's really high, stimulate and observe. If somebody's overdosing, rescue breathing and naloxone is the answer. So if an overdose happens, what do? It's pretty simple steps. So call 911. And there's all kinds of opinions about what you should say when you call 911. The key take-home message should be that somebody's not breathing. And there are people who who advise people in rural settings to absolutely say that it's a drug overdose because basic life support ambulances don't carry naloxone, but advanced ones do. And so in rural areas, they say you really should say that it's an opiate overdose. Some people say there's no reason to say it's an opiate overdose. The issue is somebody's not breathing, and they need, and you know, the EMTs are equipped to take care of the situation. And you can tell them when they get on site to minimize the likelihood that police show up. So there's a lot of different thoughts about what's the best way to, operationalize emergency medical services, but breathing, it's a medical emergency, they'll hurry. In the meantime, rescue breathing is important, especially if somebody's blue, right? If they're blue already, it means that their body is already oxygen deprived. And so people who go without breathing for like 3 to 5 minutes, they'll be like brain dead and then dead. So if somebody looks blue, they need some rescue breathing quickly. And rescue breathing is pretty simple. You put them on their back, check and make sure there's nothing in their mouth, tilt their head back, open their mouth, pinch the nose, 2 quick breaths to start, and then 1 breath every 5 seconds. And you do that if it's just one person alone, right? If I'm just sort of happen into this situation, I would do that first for 30 seconds, a minute, and then go run and get my naloxone, right? So if somebody's blue, oxygen's really important. There are lots of situations where people, you know what, I'm not paying attention to time. Okay, there we go. So there's lots of situations where people don't do rescue breathing because they were actually with the person and they're like, well, this is the point at which they're not arousable and I'm giving naloxone and they don't seem to. But anyway, so then you give naloxone. One in Illinois, the most common form of naloxone is injectable naloxone. You give 1 milliliter, which is the same as 1 cc, which is the same thing as 100 units. If after 3 to 5 minutes, continuing rescue breathing in the meantime, if after 3 to 5 minutes somebody doesn't respond, then they may need another dose. And if the person has to get left at all, then we need to put them in the recovery position so that they're sort of like this on their side, so they don't roll over on their back and choke on their tongue or choke on their spit. Oh, okay, this is my last one. So naloxone it's either nasally or injectable in your arm or your butt there. Naloxone it displaces the opiate from the opiate receptors, and it doesn't get it out of the body, it gets it just off of the receptors. And the idea is that while the naloxone has displaced the opiates off of the opiate receptors, the person can breathe again. And naloxone, which is short-acting, it acts for 30 to maybe 90 minutes, that during that time, the body is processing enough of the opiates so that when the naloxone exits, the half-life is over, the body's processed enough of the opiates so that the person isn't overdosing. I'm going to skip this. We've already talked about this. And Kathy told me this is the last one. Okay. So we don't have naloxone. We can't address overdose, right? Wrong. So anybody can provide materials and referrals. In Chicago, the Chicago Recovery Alliance is the biggest and oldest program in the country. There's a couple other programs that also make naloxone available. And there's a couple places there's a program locator on the internet. I think it's on the Harm Reduction Coalition website. You can enter in your zip code and find your closest naloxone program. Make referrals. Address overdose in counseling. Anybody who provides therapy or substance abuse treatment should address overdose. Ask people what they already do to keep themselves safe. Make a public space for grief. Passion, grief, indignance, and betrayal of public health systems really lead to some fascinating dialogues. You can do demonstrations, have shrines or altars or ofrendas for people who have passed vigils, support dialogue and activism. And I'm going to leave you with some photos of this. So we did this on International Overdose Awareness Day. We raised some money for naloxone. That's at the Chicago Recovery Alliance, naloxone there. This is an event that happened in St. Louis. These are health fairs where we're bringing up the topic and making sure that it remains on the front of people's minds. Here's a remembrance bracelet Overdose is preventable. This is a photo of our friend Terry's tattoo of her son. These pins say, I've lost someone I love to overdose, I survived an overdose, and I saved someone from an overdose. This is a vigil that happened in San Francisco where people were really trying to raise awareness about overdose, but also remember the people that they love. That's another one at San Francisco. People made t-shirts in Lynn, Massachusetts. Writing lists, just lists of people's names is really a powerful, powerful visual. In this particular event, every person who'd passed got a paper mache flower. And this is the vigil that Kathy was talking about at Roosevelt and Schomburg. So thank you very much. And these are specific people to thank. So, there we go.
Questions. We're going to be handing out cards so you can ask folks, but we're just asking you to think through your questions and write them down. Thanks so much.
So here was part of the problem. Being the good panelists that we are, we were talking in the back instead of coming up here to talk. That was my brief attempt at trying to be funny. Well, this panel, we've got professionals working in public health, law enforcement, criminal justice system, treatment and prevention, to share their personal and professional perspectives on the need for overdose awareness and prevention activities. So a highly esteemed panel. Again, there's information on their bios if you'd like to read those. But we'll start right away, and we'll just try and rotate a little bit so that, George, you're not always under the gun right from the beginning. Thank you. But could you briefly tell us what brings you here today and share with us your professional experience with overdose and why this is an important community issue?
Wow. What brings me here today is actually Chelsea back there. I met her a few months ago, and we had a lot of things in common regarding specifically heroin-related overdose deaths. Bruce Johnson, whose credentials are also on the bio, is the head of NICASA, which is a substance abuse prevention education program run throughout Lake County. And for the last several years, consistently, I've been calling Bruce in my capacity in law enforcement and asking him, when is he going to do something about all these overdose deaths? What brought me here and got me involved is the amount of overdose deaths that we've encountered, not just this year, this past year, but over the last several years. And quite frankly, I don't know what the solution is, but I'm looking for help. I'm really tired of going and talking to families, trying to explain to them why their son or daughter, their husband or wife passed away, and not being able in most situations to bring any kind of justice to them. So I'm looking for answers and a solution, as well as I'm sure most of the people sitting here.
Thank you, George. Jerry, please.
Okay, my name is Jerry Elsner. I'm with the Illinois State Crime Commission, and I came roundabout here. In 1995, I worked with a task force on China white heroin. Nobody knew what it was. I talked to suburban chiefs of police, Chicago chiefs, superintendent of police. Nobody knew what China white heroin was. They thought it was a prostitute, honest to God. And you could snort it. It was different. And I said it's going to cause a lot of problems. But it was still not heroin. It still had a negative connotation, at least in suburbia. You thought of it an inner city drug, somebody with the works, hiding in an alley, popping a vein. No correlation to anything. In DuPage County, whereas the county administrator, I said we're developing a heroin situation here, and of course at that particular time law enforcement said no, we don't have heroin in DuPage County. That's all over in Cook County, preferably in Chicago, mostly in the Englewood area. Okay, well, we had 200 prisoners in our county jail that were exposed to the HIV virus. Well, this wasn't Chicago on the north side, this was DuPage County. We assumed they got at least a good percentage of them from a dirty needle. Okay, henceforth, this was the put down Jerry Elsner, we don't have heroin in DuPage County. The Board of Realtors said so. You've heard it before. The affluent areas don't have heroin, okay? Even now they don't have it. Shoot forward, I train law enforcement with Israeli Krav Maga live fire fighting, Israeli-style self-defense for counter-terrorist groups and counter-narco groups. I had a jacket on, I was in Oak Brook. Fellow walked up to me and said, I'd like to take one of those guns and kill that son of a bitch, killed my daughter. He was serious. And I just talked to him, he said, yeah, what happened is that his daughter, sophomore in high school, very affluent area, very beautiful home, went out with the guy. And the guy came in a blue sport coat, white shirt, gray pants. He said his wife was doing cartwheels in the background. The kid had no facial tattoos, nothing like that. He took her downtown and used the entry drug. Trust me, guys. I've been there. I've been to many continents. The entry drug is not marijuana. The entry drug is alcohol. But we won't accept alcohol because that means we're doing it and we can't blame some hippie in California, okay? Let's blame the hippie. No, I'm serious about that. Let's blame the hippie. I'm going to say now, I'm not smart enough to say this is out of control. Now businessmen have it. They're running it like they do a Ponzi scheme. You get one, you get five, and speed one. I have an office on 26 in California. We have over 10,500 people in our hotel right now. We're going to have 13,000. Okay, we can no longer afford it. We can no longer arrest. If Downers Grove North and Downers Grove South have 400 addicts, they're going to have 600 next year. They're going to have 800. We cannot put Cook County Jail in Downers Grove, Illinois. We have to have a solution, and it's above law enforcement. If I can see you later, and I don't want to take your time, but if you see me later, I'll show you the money they have, the people they're hiring, and when the cartels are here. And let me tell you, the cartels are bad boys. They're not sagging their pants down to their knees. They're not the traveling blazers hanging off of the heroin highway over in Austin. These are bad boys. They shoot back. It's a whole new ballgame. We have gone from the little league to the major league. Now, my feeling is this: I want to just bring some home alive. I don't know how to stop it, but I want to keep them alive.
Thank you.
Thank you, Chair. Well, we had from Lake County George Falanco, who's the chief of police of Round Lake Park. He's also the commander of the Major Crime Task Force in Lake County. Immediately to his left and what would be your right is the state's attorney of Lake County, Mike Nerheim.
I like the emphasis on the. It's pretty good.
He actually wanted me to say superstar.
Right. Well, I'm here. I also am here because of Chelsea. And prior to becoming state's attorney in Lake County, I was initially an assistant state's attorney for several years, prosecuting all different types of cases. And I took a period of time where I was in private practice as a defense attorney for about 5 years in Lake County, handling just about every kind of criminal defense work you can. And in a small firm in Waukegan, I would lose annually probably 2 to 3 of my clients. And you tend to become close with your clients. You want to help your clients. And I always push treatment and would do all I could do to help. I've had cases where I've, in the middle of the night, gone out and literally picked my clients up out of the street to bring them into the hospital. And I got tired of losing clients. And when I was elected state's attorney, when I was running for state's attorney, everywhere I could go, I tried to talk about this issue all across Lake County. And my greatest frustration was, in a lot of places I would go, it would be like talking to a wall, because people didn't want to hear it. People don't want to see this as the problem that it is, and especially in the more affluent communities in Lake County. And I met Chelsea at the Lake County Fair, where she had a booth, and we got to talking, and it was almost like a shining light to have somebody that sees this as well, that has the same concerns as I do about bringing this issue to light. And like these gentlemen up here and this lady here, we're all here because we want to learn, but we want to help. And there's no easy answer. There's no quick fix, but this is going to take a team approach, and we're here to help out any way we can. So.
Thank you, Mike. And Maya Doe-Simkins, public health researcher and overdose prevention educator, who some have heard from, please.
Well, so I'm a public health person, and I think the reason that I'm here at this table with these lovely gentlemen is because I worked in various situations where we explored the idea of how do we utilize first responders, meaning police and fire, as people who are right there in serious, dangerous events. How do we take advantage of that presence of people, and how do we sort of introduce overdose prevention into regular practice with police and fire? And so I've had some experience with that, largely in Massachusetts, and it's been really inspiring to see what's the dialogue that's starting to happen here in Illinois. It feels like it's sort of on a verge, right? But as a public health person, I can definitively say that the answer to addiction prevention, I think, is extremely complex. But the answer to overdose prevention is actually not. So the natural history of addiction is that people get better. That's if people can stay alive long enough, people age out of addictive behaviors. And I think that we do know how to keep people alive, and now we just have to operationalize it. So there's my pitch, I guess. But it's really exciting to be here and see all of the people who are at the table and having the dialogue. It feels sort of exciting.
Well, I think you brought up, I think the beginning of, you're like the A+ student already kind of going ahead, because the part of what you touched on is that potential for coordinated efforts and partnerships. And this next question deals just with that. If public health and public safety work together to prevent overdose, what roles do each of those disciplines play? And if it's okay, Jerry, if you'd like to start.
Okay, I once again, I probably come from a different perspective than the more educated, smarter people. I'm not quite that smart. I know how to do one thing, and it's like, go after them. And what I'd like to do is, we went out in Cook County right now, we have a resolution that's coming forward. You'll hear this resolution recommending that schools, first responders, schools, hospitals, number one, use the emergency kit. Number two, educate on the 9/11 Good Samaritan law. What I'd like to do, is this. I don't believe in niceness. I was told by Lieutenant General Davis, 1967, in Quantico, Virginia, love is fickle, fear is forever. Okay? I don't want us to love them. Let's get on to the legislature. Let's mandate that every first responder be trained and have an emergency kit in their vehicle with them. Every school have that. And training for the parents through the PTA. But we can mandate the first responders are trained. They do have the kit. The schools are trained. They do have the kit. We have a school nurse in every school. If you give a kid aspirin, the nurse has to give it. That nurse can save somebody's life. And because I was talking to a couple of police officers in Chicago who said a lot of the overdoses happen in the kid's basement. Let's train the parents. If you know when your parents are on it, let's give them the option. Let's have a 9/11 Good Samaritan law for anybody that administers the antidote. Okay, let's just go through it and say, okay, now we're going to give you the immunity from it. You know, let's save the life, and just go down there and legislate it. Have the governor sign it, make it law next year.
Mike, please.
Well, I absolutely agree, and I think we do need a team approach. And one of the things we're developing in Lake County is an overdose prevention initiative that some of us have been working on for some months. And what we've identified is there are a lot of different groups of people working on this issue from different directions. You do have some people in the education sector, you have people in the health sector, you have people in the law enforcement sector. So there are some people that get it, that are working on it. But I think what happens sometimes is, even though their intentions are great, everybody is sort of working in their own direction. And what we're going to try and do in Lake County is bring all those people to one table so we can make sure that all those efforts, whether it be from public health, law enforcement, the education sector, lawmakers, get them all to one table so we're unified in our approach. And I think that's going to make us much more effective in how we tackle this, is certainly in Lake County. And I think we can be the model as we move forward across the country on this.
Thank you, Mike. Mike?
Yeah, so it's been interesting. I was part of a process that got naloxone into the hands of first responders, that developed training materials for friends and family. And the thing that's really, what's really incredible about this medicine in particular is that it's a really tangible, concrete, explicit thing that that brings a lot of different interests and people to the table. And it is an interesting idea for example, a police officer to have a paradigm shift, to think of themselves as a public health first responder. But and some people really resist it, because I think people resist change in general. But the folks, the cops who are on the ground every day were so relieved to have something, because they knew that they knew exactly who they were going to see every single day. Some of them felt like they could set their watches to when they were going to see so-and-so from such and such street overdosing, because they know he's getting out of lockup in 2 weeks. They should expect to see him in 2 weeks and 1 day. So there's something that was amazing about that process of how coming to the table with a tangible, concrete set of strategies, just it seems like the ping-ponging of well, we should do this, we should do that, they're in charge, I'm in charge, is gone, and there's action. So what was the question? Did I answer the question?
You did it. It's the roles of each one and helping to further that, because there are expertises that do need to be shared. And as you said, that paradigm shift means that you have to embrace some new things. And so you hit right on.
Can I add one more little thing then that I just
It'll cost you.
Okay, I got it. One of the things at the time I was working at a syringe exchange in Boston, and the enhancing of the relationship between myself working at the syringe exchange and police officers, we were having regular meetings. When there were situations where there was something that we were hearing on the street, it wasn't quite making sense, we couldn't figure things out. I mean, our relationships got so good that one of the narcotics chief said, well, I'll tell you what, I know that person who you're talking about has something going on that you can't figure out. We have his phone. We'll do a controlled buy of the drugs that person bought when that happened to them, and we'll analyze them and tell you what it is. And I mean, that was magic. We never had access to that kind of information before, and it makes the wraparound really impressive.
Thank you. Chief?
Well, the first time I learned about the Good Samaritan naloxone distribution emergency kits was actually in a meeting with Chelsea, and I saw the kit, and I'm a let's do it right now kind of guy. Let's get this in the cars, let's get it out to the officers, whatever it takes, and then just understanding what training was involved was very minimal. The cost to me was absolutely nothing compared to what we were going to do with it. So I got overly ambitious and immediately started contacting the fire services, my fellow police chiefs, and I thought I'd get more resistance out of the fire services, and actually they're the ones that were saying, great idea, let's get this done. This sounds fantastic. Police chiefs were more reluctant. They had this term that they use, unfunded mandates. Why are we putting more equipment in the cars? What's the point of this? And they seem to forget that we've been doing heart resuscitation with the kids for years. That's second nature to us. As far as acting like first responders and providing medical treatment, that's a given. I mean, I can't wrap my head around the fact that a police officer would actually not do that. It doesn't matter if we're EMTs or not. But one thing I did find out in my charging ahead was the bureaucracy involved in implementing a program like this is just unbelievable. It's almost shameful. Just to give you a perspective, the county itself, Lake County, is divided up into these quadrants that are managed by hospitals, and they're called project medical directors, and they regulate emergency medical services throughout the county. So each fire district is under the guise of these project medical directors. And this is the hypocrisy of what we've legislated. As a private citizen, you have more authority to administer naloxone than I do. The project medical directors are telling me, or telling us, that we actually, as first responders, have to be trained EMTs in order to administer any drug, which I think is absolutely ridiculous. And I agree with this gentleman that we need to get down to Springfield and change this law, get this into effect, and get it going as quickly as possible. And I gotta tell you, and maybe I'm stepping on myself a little bit, I have that naloxone kit with me all the time. I mean, I go to enough of these overdoses. This is a ridiculous statement I heard from one of the project medical directors. Show me a case where a police officer could have saved a life with naloxone. Well, how the heck am I gonna know that when I get, by the time you get here, the person's dead? You know, if any of you have ever seen a true overdose, the person is realistically dead until the paramedics get there and administer the Narcan, and it's almost like an experience, a life-giving experience where they just pop up and they're there. Any type of minute or 2 minute delay is absolutely ridiculous, and it's irresponsible on public safety's part not to address that issue through legislation. Sorry if I'm breaking the rules with the project medical directors. I'm going to break the rules. I've got my naloxone kit and I'm going to use it.
Your attorney says you're.
Thank you.
And if I could just,
Please.
Chief Palenka will not pat himself on the back, but I will. I was at that meeting, and when you talk about unfunded mandates, it's $20 a kit. And you're talking about saving a life, and we spend more than that certainly on bullets, I think. And this should not at all be an issue. And when we talk to law enforcement about equipping these officers, oftentimes the reality is they're the first ones on the scene. They're there several minutes at least before the ambulance gets there, if 911 is called, and those minutes could be life or death. And when we approach chiefs of police about this, we get varying responses, and a lot of chiefs are a little reluctant, and they worry about liability and things like that. But Chief Palenka, when this was brought up, his first reaction was, how much are they, and give me one for each of my officers. And that kind of attitude is really to be commended, and if we had more people like that in Lake County, I think we'd be saving a lot of lives. So I'll pat you on the back.
One thing I want to make about these calls that come in, and I'm sure I'm preaching to the choir here for those of you who are familiar with overdoses. Generally, they don't come in as overdoses. They come in as anything from a 911 hang-up call to a suspicious person. We recently had one where it was, and I hate to refer it this way, but it was a body dump. They took this poor girl and they just dumped her in a ditch on the side of the road, and luckily somebody drove by and recognized it, and she was saved. The fire department showed up and administered Narcan. But there's a lot of delay here. These are not automatic overdose calls. There's several, we get there, now we're investigating, now we're determining, so you're talking 4 to 5 minutes right there. It doesn't take that long to die. And if we're aware of the fact that this is a straight up overdose, boom, administer it. What is the big deal here? I mean, I just don't get it, I'm sorry. We just overrule ourselves at some points.
If I could say one thing, because we're all here in the Chicago area, the metropolitan Chicago area, but I go downstate. We had 97 overdose deaths in St. Clair County, Illinois last year. There's more cows in St. Clair County than there are people. Trust me, all downstate, they're dying like flies, okay? We have to get this into the hands of the first responders. You can't say, well, we'll have an ambulance, we'll have a paramedic. That may be 30, 40, 50, 100 miles away. We have to have it in the hands of the sheriff, who has a 125, 200 square mile radius, but they're the only ones there. There is no ambulance to come into these rural areas. We have to have a state law. And we have to have somebody that can do it, like our state's attorney somebody with the guts, somebody with the brain, somebody with the ambition, somebody that wants to stand with their children to head this up, and I'll get the legislators to support you.
It's great. You know, you have a overachieving panel here. The next question really had to do with challenges and opportunities relative to public health and public safety. Well, some of those were discussed, but in this case, I'm going to start with Maya. If you just want to relate a little bit about opportunities and challenges that we have.
Yeah. So one of, I mean, I think we've already talked about a lot of both of these, but a few more that I'll add is, you know, if I'm interested in inspiring behavior change in a person, I have to sit down with them and talk to them and figure out what their priorities are, right? So I've learned when working with police officers in particular that it's worthwhile to figure out what their priority is, right? And what has consistently been said back to me is that once the tone of the interaction with drug users in the community changes a little bit and police are seen as sort of allies and maybe somebody who actually saves somebody's life. I mean, the word on the street travels quick, right? So all it takes is one or two really strangely pleasant interactions with a police officer, given that it was, you know, a drug user, that the word travels. And then what that means is that then police officers have allies who are either low-level drug sellers or drug users. And that's helpful for those folks to do their jobs. So that's one sort of opportunity, is to spin it and say, here's a reason why you should go ahead and buy in, you know? And on the other hand, one of the challenges is that I consistently remind myself and others as we're having this dialogue around naloxone that the bulk of the people who are saving people's lives are drug users. And I just, it's really exciting to think about how we expand this and how do we get it into treatment, and how do we get it into jail, how do we get, you know, and I like to try to remind ourselves of that so that when we're moving forward with policies and practices, maybe legislation, we're taking advantage of that reservoir, you know, so that's my...
I think that's a well-stated comment. And I think that we're seeing, you know, with our drug courts and mental health courts and veterans courts, we're seeing law enforcement, public safety take a huge supportive and instrumental role in that, and that's that shift again.
Yep.
So please, we can come back around, George. Opportunities and challenges?
Well, part of the challenge in law enforcement, of course, is to change the culture and the thought process of law enforcement. You're talking about an old school guy who, you know, I mean, we were told to do one thing, go out there and arrest the bad guys. Pretty simple. But, you know, as time has gone on, our jobs become more and more complex, and you come to determine at some point that simply incarcerating people and getting them out of the system isn't really solving the problem. In a lot of cases, it's making it even worse. And I'm trying not to sound like a liberal right now, but fortunately, I spin that way sometimes. The challenges is breaking the culture and the thought process about heroin and opiate-related incidents, and I think that it's no longer the 60s and the French Connection, the guy laying in an alley with a hypodermic needle. It's demographics across the board, from the wealthy to the poor. And unfortunately, it took that shift in demographics to bring attention to the issue. We on our end have been fighting this for years, but nobody pays attention. My community is rather poor, and this is not this issue is not strange to us. It's strange to me to be sitting here in front of a group of people actually talking about it, thank goodness. So I think the challenges on law enforcement and just the general challenges in the public sector is to get everybody's heads wrapped around this and for what it really is. I don't know what else to say.
That's fine. Jerry, please.
Well, I see an opportunity. One thing coming in not very smart, you can always get smarter. And you know, my father, when I graduated from high school, said if you want to be smart, hang around smarter people. It's not going to be too hard for that to happen. And that happens especially now. But I have a smarter state's attorney here, and I have my public defender from Cook County here, and I was thinking we mentioned drug courts,
Yeah.
and that we have the addicts that are around most of the people dying. Well, if a condition of probation, conditional release, supervision, be that they take the class, Narcan class, that they learn how to administer this, then our state's attorneys can get together with our public defenders, and we can make that a condition for probation, supervision, or, that's it, you know? And that can be a condition. Now, every one of our drug addicts, because basically, and I work in the Veterans Court with the veterans, and in Cook County, I'm a veterans advocate. It's a volunteer position. They're my brothers. It's a drug court. Most of it, it's a veterans court, but it's mostly a drug court. I'd love to see my guys get trained in doing this. I want to bring them home alive. And if they're in a room where somebody's dying, and the state's attorneys and the public defenders agreeing upon this, then we can talk to the judges. I know we can talk to the chief judge out in DePage County and talk about this being a condition. It will save our children. And the most important thing now is not to put somebody in jail, not to kill somebody, but to save the lives of our children.
Jerry, thank you for your comments, and also thank you for your service. Mike, please.
Well, I mean, as far as opportunities, and we've all talked about it, and I mean, this is real. We have a real opportunity to actually save lives. And people talk about abstracts and things like that all the time, but this is real, and we can see how this happens. And so the opportunity is simple: save lives. And the challenges, and again, I think they've been identified. A lot of it is change. There's always reluctance to change, especially as the chief indicated in the law enforcement community. But I think drug court is a really good example of how positive change can happen. When drug court came to Lake County, I think it was about 8 or 9 years ago, I was the first prosecutor assigned from the state's attorney's office to drug court, and it was, I questioned it, and it was a unique role for a prosecutor to be in, because we're not trained to handle cases that way traditionally, and we're not used to working in a team environment with the defense attorneys and with treatment providers. So it was unnatural for me. I remember going into drug court the first day, and I was very skeptical, but I was very quickly converted, and I saw quickly that it works, and the team approach, working together to help people, does work. And every one of the prosecutors that has followed in my footsteps in Lake County and now work in drug court, again, they agree. So this change does happen, and it does happen in law enforcement. It does happen with prosecutors, and people will buy into this, and because it works and it's real. But we have to get, I think, another challenge is getting everybody again to the same table and focused in one direction, so we're not duplicating efforts or worse yet, working against each other. And again, the other challenge that I expressed earlier that is frustrating for me is just bringing this issue to light. And that's why forums like this are incredible, because every opportunity we get to talk about this is helpful, because, and as I've said before, one of my greatest frustrations is when I talk about this in certain parts of my county, nobody's listening, and people do need to listen. So,
Thank you very much. Do you have one more comment? Thank you so much. Okay, this is a kind of a vision. What does a comprehensive overdose prevention strategy look like to you, and what barriers exist in implementing such a strategy? And Maya, if you'd like to start.
Wow. Well, so the whole overdose is really, it's not a discrete thing. It's, it's part of a bigger issue. And so I guess it makes the most sense that a comprehensive strategy would have opportunities and interventions and services available at each point before we get an overdose. I mean, that's a big deal. People, even if it's a non-fatal overdose, there's damage to your tissues and organs, and it'd be really great if we had interventions all along the way. So I think that part is it's important. I don't think we know the answer to what works best in all situations, but it's really exciting to to have such a variety of disciplines at the table to vision.
Yeah, and I think your comments are dead on. I think all of those, education, prevention, early intervention, treatment, recovery, relapse prevention, those things that unfortunately funding is a issue for, that's truly a challenge for us. I think those are exact on points. Chief.
It's a complex question. I think you're very, very well facilitated to answer it more than I am. But one of the things I asked in one of our meetings was, what do we see, or what's our vision here? What's at the end of the light at the end of the tunnel? Where's the closure in bringing these programs to Lake County? And what I see is public awareness, education, in law enforcement, ground roots training for the officers, and buy-ins by them. Believe it or not, police officers, as stubborn as we can be, if you can show them why this is going to work and why this is the right thing to do, they will do it. As stubborn as they can be and as anti-change as they can be. So the picture I see in the long run is some of the things that Bruce pointed out is awareness, prevention, intervention, which are intervention in that kind of different definition in my line of work. But ultimately, I think that as far as law enforcement is concerned, it's awareness and changing the mindset and education.
Okay, I'm in entire agreement, but there's no but here. I have just a different approach. If you look, everybody look to their left right now, look to your right. I'm going to use the Mothers Against Drunk Driving approach. You had 5 women sitting around the table. And I remember, because I'm older than anybody here, I hate to say that, Jesus God, but I'm older than anybody here, is that it used to be on the Johnny Carson show, I'm glad my car knew the way home. Remember that joke? Boy, I got in the driveway. But it's no longer funny because 5 women sat at the table. We want to change it. We can change it this year. What we have to do is this. We have the public defender back here, and he is the lobbyist for the Cook County Public Defender's Office. Great guy. We have the state's attorney here. I know he'll work with Jim Glasgow, Bob Berlin, these guys. The chief's here. We can get the I can't speak, but I'm sure we can get the South Suburban chief to support us. What we do is we go down to Springfield. Everybody has a state rep and a state senator. Let's get together under the guise of Roosevelt, all get together and say, this is what we want. And I'll tell you, this is what we will get. And we will get it not next year, we'll get it this year. It's just everybody here is from a different area. We all have different state reps, different state senators. We can get this done. We have to convince 2 people, a guy named Cullerton and a guy named Madigan, okay? 2 people. Not a whole bunch of them, just 2. If 2 of them like it, we get it, okay? So what we should do is get together after this, decide how we're going to do it and get it done. We can even get it through a veto session because there's so many of us and we are saving the lives of children.
Yeah, and Jerry, to your point, I think that some of that work has started. There was a bill that got out of committee relative to a statewide heroin task force. A representative from Lake County had pushed that through committee. It's on its way, but you're right, it's only the beginning, and certainly there's a lot of strength in everybody getting their elected officials.
If I could just say this, well, and I just have to brag about our group for just 1 second, okay? We took on the liquor industry when we did dram shop reform. Prior to this legislation, stay-at-home mothers had less worth than a dog. If a drunk driver hit a dog, you'd be reimbursed for the cost of the dog. If it was a stay-at-home mother, she had no worth. We changed that. We took on the liquor industry. We were also the ones that took guns away from wife beaters. Right now, if you're convicted of domestic battery, you can no longer possess a weapon in the state of Illinois. We did that. If we can take on the gun industry, and we can take on the alcohol industry, we can get this done in this session.
Thank you, Jerry. Mike, please.
Love the way you think. It does get frustrating because you want to act, you want to go and get things done, and with this kind of attitude, I think we can. And I don't know that, I think the commission is great. It's a great thing to do, but I don't know that we need a commission. I think it's obvious that heroin is an issue, it's a problem. Overdose is a problem, and we're sort of beyond that now. What are we gonna do about it? How are we gonna fix it? And what does a comprehensive policy look like? And I think it's, again, it's having all those different people, whether it's treatment providers, law enforcement, the medical people, have everybody at one table and grow this table and really make sure we're all unified in our approach to this issue.
I think that's a great comment, Steve. Okay, kind of quickly on this question, because there's some audience questions. Kind of touched on this, but maybe just another point. Given the tools that we currently have to address overdose, 911 Good Samaritan laws, and naloxone distribution, how do we move forward in Illinois to reduce overdose deaths? So some last points of good ideas. Maybe start with you. We're back around.
I'm going to go back to public information and education. Again, I'm admitting I was not completely aware of the Good Samaritan laws with regards to heroin overdoses. And I can tell you that I'm very well informed usually. I do a lot of reading on changes in the laws and that. And I feel ashamed that I didn't know about some of the changes that occurred here. And I'm going to tell you, if I don't know, then probably about 90% of law enforcement doesn't know.
I don't know either. I didn't know until a couple weeks ago. But what I'd like to do, once again, go down to Springfield and mandate that this become part of the driver's education program. That every young person in Illinois be informed of this law and make it part of the program.
Again, I think moving forward, is the prevention initiative we're starting in Lake County is a great first step, and having, as I keep saying, all those people at one table working together, educating law enforcement, educating the community. I know we will save lives, and I love the spirit in this panel, and I know Jerry would probably, sounds like he'd be ready to jump in a car right now and go to Springfield, and we'd all probably go with him. So that's the enthusiasm we need, and keep it going.
I want to talk turkey. I think we need to expand naloxone access programs, and we need to provide state level, federal would be great, funding and support for those programs. As it is right now, I know from my collaborations with the Chicago Recovery Alliance that it's a full-time job to raise enough money to buy the naloxone that they give out, and it's unfunded. The State Department of Public Health, the feds, this is all like us pulling out our wallets and making donations and making sure that we're contributing to that. And that's just not how good public health systems work. Public health systems are supported by, public health interventions are supported by public health systems. So,
Well said.
There you go.
We're right on schedule. I'm going to jump into some of the audience questions. And Maya, just because you just got done talking, this one seems to be written for you. What happens to the person who is injected with Narcan if he or she doesn't have heroin or opiates in her system? Are there any side effects?
That's a great question. I should have said something about that already. Naloxone is a pure opioid antagonist. Its only mechanism of action is to attach to those opioid receptors in the brain. So if there are no opioid receptor or no opioids involved, it doesn't have any effect. So it's pretty safe. I mean, there are very few adverse events. There's not really any contraindications. It's a safe medicine.
Thank you. This could be for the chief, Jerry, Mike. What steps could be taken to change the public perception of our local law enforcement as helpers in overdose prevention? So how can we change that kind of shift that paradigm?
I think you brought up the point, or somebody did, regarding trust factor between users and law enforcement. That anytime there's an encounter with us, it's not necessarily punitive. And I recently did have an encounter with a young woman who was 19 years old, drug user. heroin user specifically. She had overdosed, and actually I wound up arresting her at the insistence of her boyfriend, who was also a heroin user, because he had literally begged me to arrest her because he felt she'd be dead in a couple of days, and she had expanded her use that much. I think his action, coming to me and having trust in getting her into the system and knowing that this wasn't just a getting her into a jail situation, and we were going to follow through and make points of contact with certain organizations and offer her some assistance, that word does spread pretty quickly. You know, when we take action on the street with issues like gang enforcement and we send a clear message, it's like that. It's faster than we can communicate. So I think it's important to establish that rapport. I agree with you completely.
Okay, thank you. Since they're often first on the scene, have any police departments in Cook County been provided with Narcan? And I guess that might be a question for Kathy. No. So the answer is no, but I'm positive that just as is in Lake County, that's a future initiative. That's a push.
What I would like to say is this: if we get the legislation, all of them will have it. All of them will have it. It'll be.
Well, Jerry, so because you say that, because you just happen to mention that, on the flip side of this, you know, there's a question that really relates to legislation and why things get done or don't get done. As someone who grew up in Fox Lake, Lake County, and have had a number of friends die from overdoses, when I went to Springfield for a Good Samaritan bill 5 years ago, we couldn't get the bill out of committee. Why does it take a lawmaker or police officer's kid to overdose and die to get the political will to change?
Once again, and everybody on this panel can disassociate themselves from me right now, but I don't care if I'm politically correct. Love is fickle, fear is forever. We go down there to kick some butt, okay? And they know we're going to do it. We're going to go to the papers. First people we go to the media. We set them up. They know. We convinced the media that we're sincere. This is what we want to do. When we took on the gun industry, we took them on. We took guns away. We tried to take on the FOP because they thought, well, because of the police officers involved with domestic violence, they'd lose their guns. Well, tough luck. I mean, does that make their wives second-class citizens? But the point is, you have to go down there, and you have to go down there with a purpose. If you go down there trying to be nice and win them over, you don't spend as much money. You don't have as much money in this room as the gun lobby, alcohol lobby, tobacco lobby, any lobby, okay? All you are is mothers and housewives and people that care. You go down there as a group, and you have to understand, these guys do this for a living. If you threaten their livelihood, they'll vote your way. Once again, that's it. We, working with Security Systems International out of Tel Aviv, you know, we got the whole continent at bay, okay?
Well, and Jerry, this question, you know, it actually had your name on it, but I think you've really pretty much answered it, and it's in regards to Illinois advisory referendum on treatment on demand, passed in 2004. So treatment would be available on request. It's never funded. We need more than advisory action, and this is what we're going to have to do to get it. So we will have to fight. So I could answer that for you. Okay, this is the last question that we got from the audience, and I want you to know we're right on time. Certainly a few of you could speak to this. Can you foresee a change to Illinois drug courts where people are diverted prior to arrest and sentencing to avoid damage done by a criminal record? And I know, Mike, you can speak to that.
Yeah, there's some pretty exciting programs that other counties have utilized that we don't currently have in Lake County, but I've only been in office for 3 months, so I'm working on it. But we are going to model our program off of a program in Kane County, which is called the Second Chance Program. And essentially what that is it's for first-time nonviolent offenders, which includes felony cases, it includes drug cases. If they're accepted into the program, they are They get job training, skills, treatment. If there's a victim and the victim consents, they pay restitution. But the charges are either diverted or dismissed at the successful completion of the program. And what's important about that, which is alluded to in the question, is what we see a lot are people that pick up these first time, again, nonviolent, oftentimes arrests. They receive a conviction. There does seem to be a tremendous disparity in those that are convicted and those that are not. But then that conviction stays on your record forever, which does help to sort of perpetuate this cycle into the criminal justice system. If we can get those people sort of in and out without having that record, and let them get back into society and be productive members of society and get jobs and do all those things that we all want to do, I think it's a win-win. So the program's been very successful in Kane County. We're going to bring it to Lake County. I think Cook County is in the process of doing something along those lines as well. So these programs do work, and offices across the state are paying attention and changing.
And Mike, knowing we have the right guy in the state's attorney's office in Lake County, Mike has volunteered for years and years for our teen court program, which is the largest teen court program in Illinois that does just that with youthful offenders. So he understands that very, very well. So it seems like a natural extension. Just two comments. I want to thank the panel for their experience, sharing their expertise with us. And I really want to thank Roosevelt University, Illinois Consortium on Drug Policy, Kathy, Stephanie, Chelsea, everyone for the help that they're giving Lake County, but also for bringing this, this forum today. So if we could have a round of applause for the panel. I know at some point we're adjourning. Were there any, is there a final comment from anyone? Chelsea? You've heard her name mentioned so many times. Really the superstar.
Thank you. Hi, everyone. My name is Chelsea Laliberte, and I am the newest member of the Illinois Consortium on Drug Policy. I focus on strategic partnerships. And when I met Kathy and Stephanie at last year's International Overdose Awareness Day Candlelight Vigil at the Schaumburg campus, they knew me as the co-founder of Live for Lolly, which is a grassroots organization that focuses on drug awareness that I started with my family in 2009. And I did that because my younger brother Alex died of a heroin overdose, December 15, 2008. He was only 20 years old. And every day that I wake up in the morning, I am reminded of that just by breathing. I can't look at him, talk to him, tell him I love him ever again. And when Alex died, my parents and I were pretty clueless as far as his illicit drug use or understanding opiates and heroin at all. Even the word heroin was like, growing up in Buffalo Grove, it just wasn't a word that you heard like anywhere. Or what it did, physiologically to his body and what kind of resources that we had available. But, how are we to know any of this? We were never taught anything. And naloxone, what? Like that's the ground that we stood on. We felt like we had failed through our own ignorance. And, Alex was a good, kind, and loving person. We thought we grew up in a safe environment in Buffalo Grove. We had a religious upbringing. We were taught treat others the way you want to be treated. But we stereotyped like the rest of the world, thinking that overdose could not happen to us, to our family, and clearly we were very wrong. So thanks to my work at the consortium, I understand how overdose is a preventable event. My work is to take the research and the recommendations developed here and go out into the suburban communities who need it the most to build relationships, and if we're lucky, partner with leaders and stakeholders to create programs in effort to change the culture. I'm proud to say that it is working with our amazing team over here in Lake County that we're getting ready to roll out. So on behalf of everyone at the ICDP, I just wanted to say thank you for coming here today, supporting our program, for taking the time to re-examine our drug policies. I'm also here to say that this work does not stop when you leave. There are many actions that will be planned in the coming months to help end the overdose crisis. The price of naloxone, for example, keeps going up, all the way up to 1,100%, not 100, 1,100%. This means that nonprofits who distribute it to prevent overdoses are going under. The Chicago Recovery Alliance, the largest distributor of naloxone in the Midwest, if not the country, has seen prices double, triple, and quadruple. To us, this is a complete outrage, and we hope that the one maker of naloxone, Hospira, will work with nonprofits to make sure their naloxone is distributed to save lives. We plan this year to mark the occasion of International Overdose Awareness Day, which is August 31st, with 10 days of action. Look for alerts from us for our rally at the Federal Plaza to ensure that naloxone continues to get distributed, and watch us as we honor the lives lost to OD. Join us for events and fundraisers, concerts, and marches, which will begin August 23rd. I know I will not rest until we begin to see some relief from the OD crisis. I know we have the tools in Illinois, and we are beginning to see the political movement to really address this crisis. I also want to point you to something that you can do right now when you leave here, for all the people who are in recovery but have criminal records because of their addictions, because I have learned that the people pay the penalty for their substance use disorders over and over again. They pay with jail and court time, and then they pay again when they are unable to get a job or an apartment because of an old conviction, because they were once addicted. So please look at information on HB 3061, which you can, House Bill 3061, which you can get information up at the desk for, which is also called which is the ceiling bill, so that those who have survived and who are now in recovery can get the jobs they need to support their recovery. I am here because my story is why our drug policies need to be re-examined, so that another Alex and another Chelsea 15 years from now with a similar version of my life will never experience what I have. That person in the future, hopefully, will not have to go through what I went through and what I hear about every day from my friends like Caroline sitting there, who lost her son, and Cassandra, who lost her fiance in the back, and Michelle Hines, who just left, whose son is in recovery. And there is hope, and I know that there is, and there is action as well. I am hopeful, but I know I cannot do this alone. In order to change these problems, you must act, we all must act, and we must do this effectively, strategically, and quickly. Thank you very much for coming.